All right, now we're going to talk about acid-base disorders. So you've already heard about normal acid-base physiology. Now we need to get to what happens when things go awry. Okay? So you've seen this before, the normal pH between 7.35, 7.45. So when there is a process that moves the pH outside the normal range, those are the acid-base disorders. So any process that pulls the pH down is called an acidosis, okay? So remember, just to be technical, acidemia is when the pH is actually below 7.35, and acidosis is any process that is pulling it down. Alternatively, an alkalosis is any process that's pulling the pH up, okay? So if the pH finally goes above 7.45, that's an alkalemia, okay? So alkalosis is a process, acidosis is a process. Now, we have robust mechanisms, and I've hinted at a few of these in the prior lecture, but these mechanisms we call compensation. Remember, our body is designed to sort of mitigate changes in the pH, and so compensation is a normal physiologic response that opposes the primary disorder. Okay, so compensation is something that's going to happen in response to the primary disorder to pull the pH back towards normal. Okay, one key point, compensation never brings the pH back into normal range, but it does bend it towards the normal direction. Okay, so compensation never pulls it all the way to normal, but it does mitigate the degree of change. Okay, so this is probably one of the most important things, and I feel privileged to be the first pass at acid-base disorders here. So this is going to be something you're going to use, I think, for the rest of your doctoring career. Okay, so the cardinal acid-base disorders and expected compensation. Incredibly important. Let's go through it. Now, we do have to show the Henderson-Hasselbalch equation. pH equals the pKa of the primary extracellular buffer, which is bicarbonate and carbonic acid. So the log of bicarbonate over the PCO2. So think about this. The pKa is not really going to change. The amount of CO2 that's dissolved into plasma is not really going to change. So the only things that can change is the bicarbonate concentration and the PCO2, the partial pressure of CO2. So a metabolic disorder, by definition, is some process that's affecting the concentration of bicarbonate in the plasma. A respiratory disorder is a process that's going to affect the partial pressure of CO2. Okay? So now look at our disturbances. The 4 cardinal disturbances. You can have a metabolic acidosis, which has a low pH. You can have a metabolic alkalosis, which has a high pH. Okay? You could have a respiratory acidosis, which has a low pH, or a respiratory alkalosis that has a low pH. Okay? All right, now let's define each one. Let's fill out the table. So a metabolic acidosis, if the pH is down and it's metabolic, that means the bicarbonate's the problem. So what would be the problem with bicarbonate? Oh, it's too low. Okay, so bicarbonate's low, pH is low. What would be the compensation? So, okay, let's take a break here. Now think about the equation. This is just a ratio. There's stuff on the top and stuff on the bottom. The thing that can change on the top, the thing that can change on the bottom. Remember, the pKa is not going to change too much. The only thing that would change is the log of this ratio, the log of the thing on the top over the thing on the bottom. So if you wanted to mitigate the change in this quantity, what would you do? Well, whatever the change is with one variable, you'd want the other variable to change about the same, so the ratio overall does not change very much. Okay? So what I'm really saying is, if the top number, let's say the top number went down by some amount, well, in order to mitigate a change in the overall pH, I would want the PCO2 to drop in a similar fashion so that the overall ratio doesn't change too much. So if I was designing the human body, what would be the compensation? It'd be something that drops the PCO2. Okay? The primary process for a metabolic acidosis is that the bicarbonate gets low. If I was going to try and mitigate that, the change to the pH, I would drop the PCO2. Okay? Metabolic alkalosis, the bicarbonate's too high. All right. So if I want to mitigate that change, what should I do? My compensation, I'm going to try and increase my PCO2 in some way. Okay. All right. Now, respiratory problems. The primary disorder is a change in this PCO2. So a respiratory acidosis, if the pH is getting low, I think this is getting high. What do you think? Oh, yep, I'm right. So the PCO2 is getting too high. Okay. Remember, retaining CO2, it's equivalent to retaining acid because that CO2 will convert to carbonic acid and that will generate protons. Okay. So if the PCO2 is getting high, what would be my compensation to try and mitigate that change? It would be to increase the serum bicarbonate concentration. Likewise, a respiratory alkalosis. Now the pH is getting too high. The primary process is that the PCO2 is getting too low. Okay. That's the primary process for a respiratory alkalosis. Now, if I want to mitigate that change, what would I do? Yep, you're right. I would drop the bicarbonate concentration. Okay. This is key. I think you do have to memorize or figure out some sort of scheme for memorizing this type of table. And kind of one easy way is you could at least remember the metabolic processes. All the arrows go in the same direction. Down, down, down. Metabolic process, up, up, up. The only one that's kind of funky is the respiratory ones, where PCO2 and bicarbonate, they're always going in the same direction, but the pH is in the opposite direction. Okay, so this is key. Here are your disturbances. Here's the primary process, and this is what is happening with compensation. Now let's talk about compensation more directly. Okay, for each disturbance, let's start with metabolic acidosis. The primary process is the bicarbonate is getting low. Let's talk about the things that could do that. Number one, maybe we're just unable to get rid of that acid that we're generating every day. Remember in the first talk, we talked about how the kidney is excreting protons. Well, this is sort of an easy mechanism. The kidney's not working. Okay, so renal failure, either acute kidney failure or chronic kidney failure, end-stage renal failure. Basically, you can just say if the kidney's not working, that can lead to metabolic acidosis because there's about 1 milliequivalent per kilo of acid generated every day. And if your kidney's not working, that acid's going to build up. Okay. There's also a cluster of diseases called renal tubular acidosis, which is, well, the kidney function is fine. Like the GFR is totally fine, but there's something wrong with the tubule itself. The tubules are poisoned, and that's leading to an acidosis. That's called a renal tubular acidosis, also RTA. Also, you can get a low bicarbonate from losing fluid that is rich in bicarbonate. The biggest thing is diarrhea because gastrointestinal secretions past the stomach are rich in bicarbonate. So diarrhea, you lose bicarbonate, okay? Also, you can lose bicarbonate from the kidney. What if the proximal tubule got poisoned? Okay, remember you reabsorb bicarbonate in the proximal tubule. If that part got knocked out, got poisoned by whatever mechanism, but the GFR and tubular flow is fine, well, now you're going to pee out all that bicarbonate. That can lead to metabolic acidosis. Okay, the third big category, rapid production or addition of acid to the body. There are three big categories. Number one, ketoacidosis, like we see in type 1 diabetics who do not have the ability to make insulin. They go into starvation. The other one would be ingestion of some toxin that is converted to an acid in the body. So salicylate poisoning is addition of the acid, and then methanol and ethylene glycol are toxic alcohols that are converted to acid in the body. The third big category is a lactic acidosis, which comes from a global perfusion problem, and basically our cells convert to anaerobic metabolism in order to stay alive, and that generates a lot of lactic acid. Okay, these are the three big mechanisms. We can't pee out the protons. We're losing too much bicarbonate either in the stool or in our urine, and then we're generating acid, or we added acid to the body. Okay, compensation. So the bicarbonate is dropping for one of these three reasons. Basically, we're going to have to ask ourselves the question, well, how much should the PCO2 drop? How much will we compensate by hyperventilating? Think about it. You're going to hyperventilate to get more CO2 out of your body. The Winter's equation is the answer to that. the expected PCO2. And so this is important. For what degree of low bicarbonate should the PCO2 drop? The expected PCO2 is this equation. It's 1.5 times the serum bicarbonate plus 8. All right, that gives you some answer, some number. And then there's wiggle room on the side. There's a plus or minus 2 fudge factor because it's not always perfect. Sometimes it is, but there's a little bit of wiggle room, and it's kind of cool. This came from a old school study. Dr. Winter was a physician who was a pediatrician and did this study in newborns who are having profound diarrheal illnesses, and essentially, with simple algebra, solved the equation that became Winter's equation. So as you can see, as the plasma bicarbonate gets lower, the PCO2 gets lower and lower. And this is compensation for metabolic acidosis. We hate to use that term memorize. I hate to use the word, you got to memorize this, memorize that. I feel like this is one thing you got to memorize. You got to have this in your brain because when you're treating patients sort of at the moment and people who are really sick, have complicated problems, you got to be able to use Winter's equation on the fly to figure out what's going on with their acid-base disorders. Okay, so I'm saying this is really important. You got to memorize it. You're going to use it. It's on many tests. Enough said. All right, metabolic alkalosis. The primary process, the bicarbonate is too high. Now, what can do that? Well, what if someone was ingesting way too much bicarbonate solution? There is something called the milk alkali syndrome, which we don't really see anymore, but it's there in the textbooks. It's from ingestion of like too much Tums and calcium containing liquid to cure someone's like peptic ulcer disease. So that's one way to get it. Also, I'd say the most common thing would be excessive loss of protons by some mechanism. So GI losses from the stomach up. So excessive vomiting leads to a loss of protons, and NG suction would be a nasogastric tube on suction, and this happens in the hospital. Sometimes we have to do that for certain patients. Also, you can lose too many protons in the urine. So diuretics can do this, and I mentioned this in the prior lecture. Diuretics can stimulate bicarbonate reabsorption proximally, and it stimulates proton secretion distally. And also hyperaldosteronism, right? Because those distal proton secretion processes are stimulated by mineralocorticoids. So if someone had a tumor secreting way too much aldosterone, it can basically stimulate that to a disorder like a metabolic alkalosis. Okay. Now, there is this entity called the contraction alkalosis, which I also mentioned in the prior lecture. This is where someone is developing volume depletion or chloride depletion, and the classic example is excessive diuretic use. And the proximal tubule will reabsorb way too much bicarbonate than it otherwise would in order to maintain appropriate volume status. So if there's not enough chloride to reabsorb with that sodium, the body will say, oh my gosh, well, I'll just reabsorb this filtered bicarbonate even if I have too much of it. I'm willing to cause a metabolic alkalosis in order to avoid cardiovascular collapse and volume depletion. Okay. All right. So the compensation is, you're right, increase the PCO2. So if the bicarbonate is rising, the pH, right, is rising. In order to mitigate that, you will retain CO2. And how do you do that? Well, you do that by hypoventilating, by breathing less, okay? Breathing less deeply and less frequently. There are two equations for this. Basically, what is the expected PCO2 given the serum bicarbonate? So there's two published equations. One is 0.9 times the bicarbonate plus 9. The other one is 0.7 times the bicarbonate plus 20, plus or minus 5. And, this has a pretty wide wiggle room range. And there are two equations here. It is hard to remember this one. I sometimes even have to look it up. But I guess the 0.7 times the bicarb plus 20, that's the one that kind of sticks in my head easily. I think this is something that's okay to look up when you need to. I would rather have you memorize Winter's equation if you had to pick one, just because acidosis is clinically more common than alkalosis. All right, respiratory acidosis. All right, the primary process is that the PCO2 is way too high. Think about this. we are normally ventilating off this 15,000 millimoles of CO2 per day. This problem is because something is interfering with ventilation and gas exchange, okay? And this is kind of an interesting differential. You have to run through it and say, well, geez, is it because the brain is not working well? Is there trauma or an infection in the CNS or a tumor or a stroke or something affecting the medulla and preventing the patient from appropriately ventilating, okay? Also, what if the respiratory muscles are just weak, right? And that could be a neuromuscular problem. It could be a muscular problem. What if it's a problem with the thorax, a big pleural effusion compressing a lung? What if there's air in the chest cavity compressing a lung and you can't ventilate? Intrinsic lung disease, there's obstructive lung disease, restrictive lung disease. You could fill the alveoli with fluid or inflammatory fluid. There are many different reasons for a respiratory acidosis, but the big picture I want you to take away is that it's anything interfering with ventilation. Now, the compensation, well, to compensate for a respiratory problem, we have to go to the metabolic processes, and the kidney is going to help us hold on to bicarbonate. So we're going to generate more bicarbonate and hold on to it. That will mitigate a respiratory acidosis and a drop in the pH. All right. A respiratory alkalosis. Now, this comes from an extraordinarily low PCO2, and if you think about that, it has to be kind of a central process. Basically, this is someone hyperventilating, and maybe they can help it, maybe they can't. It's kind of hard to make yourself hyperventilate that long, so it has to be something that's centrally driving it. Okay, so anything that stimulates ventilation and gas exchange above and beyond normal. And it tends to be a central process, a central nervous system process. So excessive pain, anxiety attacks, fever, stroke can do it, infection in the brain causing encephalitis. So it could be secondary to hypoxemia. So maybe the person's hyperventilating just to keep the PO2 normal, but the consequence is that they're ventilating off too much PCO2. Some drugs and hormones can do it. Again, intrinsic pulmonary disorders, brewing sepsis, like an overwhelming infection is coming, and also mechanical hyperventilation. Sometimes it's our fault when we're controlling someone's ventilation if they're critically ill. Okay. Now, what's the proper metabolic compensation for these respiratory disorders? Now, this is a little bit of a, somewhat complex table, but I think it's worth memorizing, and I think I have a way to get you to memorize it. So there's one thing to take note of. You can have an acute respiratory process and then a chronic respiratory process. Acute respiratory process, think about something happening over, numbers of hours, whereas chronic respiratory process, now we're talking about days and days and weeks, okay? So with an acute respiratory process, the change in partial pressure of CO2, for every 10 increase in the PCO2, the bicarbonate should go up by about 1, okay? And actually, this kind of buffering is sort of that acute, movement of PCO2 into red blood cells, and it gets split, remember? And then there's some buffering of the proton, and then there's an increase in bicarbonate. So this is kind of the acute buffering of a PCO2 rise. An acute respiratory alkalosis, that'd be a change in the PCO2 going down. And so for every drop in 10, okay, every 10 decrease in the partial pressure of CO2, the bicarbonate should go down by about 2, okay? Remember, these two quantities are going in the same direction in both cases, okay? Now, one interesting thing worth noting is that for the chronic disorders, you can see that we sort of augment and recruit a little more capacity to buffer. And this is because the kidney has now had time to recognize the problem and kick in and basically upregulate tubular function, tubular energetics, and the transporters responsible for buffering. And so with chronic respiratory acidosis, so let's say over days and weeks, the PCO2 has gone up by 10. For every 10 increase in the PCO2, you'll see an increase in the bicarbonate by maybe 3 to 4, okay? For every 10 chronically, the bicarbonate should go up by about 3 to 4 for every 10, okay? Likewise, for a chronic respiratory alkalosis, which can occur, for every drop or decrement in the PCO2 by 10, it should decrease by about 5. And really, the reason why this is more robust chronically than the acute process is because renal compensation has had time to kick in. And so the kidneys have gotten the signal so strongly, they're like, all right, guys, we just got to upregulate tubular function. We got to increase activity of these transporters because clearly the primary problem is not going away. All right. Now, how to memorize this thing. So here's my trick. This is how I memorize these things. So keep the delta PCO2 in increments of tens. Okay. So delta 10, delta 10, delta 10, delta 10. Okay. Now take your disturbance and alphabetize the disturbances. Okay. Acute acidosis, acute alkalosis. See, because ACI comes before ALK. All right. And then the acutes, AA, comes before the chronics, CC. So acute acid, acute alkalosis, chronic acid, chronic alkalosis. All right. So keep all these in tens, alphabetize these 4. Now, once you've done that, all you have to do is count to 5. 1, 2, 3, 4, 5. All right. So once you alphabetize these, make a table, count to 5. 1, 2, 3, 4, 5. Now the arrows, you just have to figure out the arrows. And as long as you have a good sense of, well, in acidosis, the pH should be low, and you know what the primary process is, that the PCO2 is high in an acidosis, it's low in an alkalosis, high in an acidosis, low in an alkalosis, you can get the arrows for everything else, okay? So that's how I have been able to memorize that. Just alphabetize and count to 5. Okay, so now let's approach some simple acid-base disorders. This is really important. This is going to help you literally take care of patients, okay? So here is a step-by-step approach for simple acid-base disorders, and this is sort of the appropriate for, like your level right now. So you need to first look at the pH, the PCO2, and the serum bicarbonate in order to determine the primary acid-base disturbance, okay? You need all 3 values to do that. If you don't have one of them, you can't really make a good call, okay? Remember, the pH just tells you whether it's in the normal range, whether there's acidemia or alkalemia, but you need everything to understand how many disorders are present, okay? Because I'm going to jump a little bit and say you can have multiple acid-base disorders present in one person at one time, okay? You can actually have 3 acid-base disorders present, believe it or not. So you can have 1, you can have 2, you can have 3, and I'm going to show you how you can think about it and at least figure out whether there's 1 or 2 present, okay? All right, so figure out the primary disturbance, and that's using that table that we showed you earlier. pH, PCO2, bicarbonate. All right, next, it is important to calculate the anion gap, and the anion gap is the serum sodium concentration, subtract off the chloride concentration, subtract the bicarbonate concentration. That basically tells you whether the acidosis, if there's an acidosis present, it tells you whether or not it's due to the addition of new acid or not. Remember, in the acidosis slide I showed you, there's 3 different ways to develop acidosis where lactic acidosis is present, ketoacidosis is present, or you ingested some new acid, okay? This is how you determine that. That's how you find something like that. You would see an elevated anion gap, okay? If you have an acidosis due to diarrhea, or maybe the kidney's not reabsorbing the bicarbonate, or there's the tubular problem, it's generally a normal anion gap acidosis, okay? Kidney failure can have either a normal or a high anion gap. So the anion gap really helps you with the differential diagnosis for a metabolic acidosis, okay? So I have to include it here, but I'm not really going to quiz you on it right now, but be aware of it. Next, understand the primary disturbance, but based on that primary disturbance, now you have to calculate the compensation and say, you know what, based on what the primary disturbance is that compensation appropriate or not? Like, is it right on target or is it off target? Because if it's off target, then there's another disorder present, okay? So if that compensation is appropriate, then you're done and you say, oh, well, great, that was just a simple, metabolic alkalosis with normal compensation, we're done. But if that second quantity is somehow off base or not what you expect it to be, then there's another disorder. Let's do some examples. Okay. First, 58-year-old female after bowel surgery says she's had nasogastric decompression, which is like a tube was in her stomach sucking out fluid for 5 days, and she feels weak and dizzy. Okay. The pH 7.51. So I want you to answer, is it normal? Is it low, or is it high? It's high. Bicarbonate 35. Remember, the normal range is around 24, so that's high. The PCO2 45. Remember, normal is like 40 to 44, so it's a little high. So I'd say the pH is increased, the bicarbonate is increased. So already I would say this is a metabolic alkalosis. Okay, pH is high, bicarb's high. What would be the expected PCO2 for a metabolic alkalosis? Well, 0.7 times the bicarb plus 20 plus or minus 5. Okay, so with a metabolic alkalosis, I would expect the PCO2 to be a little high, okay? And I would call this a metabolic alkalosis with appropriate respiratory compensation, okay? Remember, for the metabolic disorders, if it's a simple one, all the things are moving in the same direction. Up, up, up. Okay, that was easy. Next one, 30-year-old female, poorly responsive and not breathing after she got sedation for some outpatient procedure, okay? pH 7.25, is that high, is that normal, or is that low? Okay. I think it's low, okay. The bicarbonate 26, what do you think? Well, it's kind of it's a little high, but it's kind of close to normal, but maybe a touch high, okay. The PCO2 of 60, all right? Remember, normal is like 40, that's high, okay. So the pH is low. The bicarb is up a little bit, but the PCO2 is high. So what's the primary disturbance? All right, pH is low. Is it a metabolic problem? No, I don't think so. This is a respiratory acidosis. pH decreased, CO2 increased. Respiratory acidosis. That's the primary problem. She's not breathing, okay? So now that we know the primary problem, we ask the question, well, is that bicarbonate like what we would expect? And so remember, you go to your table. So let's say the expected bicarbonate, it would go up by 1 for every increase in the PCO2 by 10. Remember, this is an acute respiratory acidosis, okay? It sounds like she was like healthy, but we did the procedure and now she's not breathing. So this happened pretty fast, okay? So the bicarbonate, normal's 40, it's now 60. The delta is 20. So the expected bicarbonate, we'd expect it to go up by 1 for every 10. All right, it went up by 20. Okay, so the delta bicarb was 2. That makes sense to me, okay? Change in bicarb is about 2. The change in PCO2 is 20. That's like a 1 to 10 ratio. That's perfect. So I would say this is acute respiratory acidosis with appropriate metabolic compensation. All right, 32-year-old male, 10 days of watery diarrhea, okay? The pH, is it high or low or normal? I'd say low, okay? The bicarbonate, high, low, or normal? Low, 9 is low, normal is 24, remember? And the PCO2, is that high, low, or normal? That's low. Remember, a normal PCO2 is 40. Okay, so everything's low. So what's that? pH is low, bicarb is low, metabolic acidosis. Now, for a metabolic acidosis, we have to ask the question, all right, that PCO2 is low, but is that appropriate? Like, is that where we would expect it to be? So we do Winter's equation, 1.5 times the bicarb plus 8, and then you have the plus or minus 2 fudge factor. So if you do the math, I get about 21.5. It's close enough. So that means the patient has a metabolic acidosis because of the bicarbonate loss from all the heavy diarrhea. He's hyperventilating. He's hyperventilating on purpose to bring the pH back up some, okay? It would be so much lower if you were not able to compensate by hyperventilating down to a PCO2 of 23, okay? So I would say here, this would be metabolic acidosis with appropriate respiratory compensation. Okay. All right. Man unresponsive with a thready pulse, okay? pH 7.1. Is that high? Is that normal? Is that low? Okay, that is low. Remember, normal 7.35 to 7.45. The bicarbonate is 15. Okay, remember, normal is around 24, so that is low. PCO2 of 50. That is high. Ooh, okay. So, well, what's going on? Okay. Well, you could start from either direction, but at least, right, you could say there's a metabolic acidosis. But you could also say there's a respiratory acidosis because the PCO2 is high, all right? Wow, this could be like both going on perhaps, all right? Well, hold on, let's just do one at a time. All right, the pH is low, bicarb is low, there's at least a metabolic acidosis. So let's do Winner's equation. Remember I said it's important? 1.5 times the bicarb, 15, plus 8 plus or minus 2, we get 30.5. So that tells me, all right, if this was a pure metabolic acidosis and his brain was working, his lungs were working, and he could hyperventilate, he would hyperventilate down to a PCO2 of 30. But his actual PCO2 right now is what? It's 50. It's way higher than what I would expect it to be. So he is not compensating. He's got two problems, okay? The actual PCO2 is higher than what I expect it to be. So he has two problems. He has a mixed metabolic acidosis and a respiratory acidosis, and that's why his pH is so low. So he's very sick. This is a very common clinical scenario that you will see. That's why I want you to memorize Winter's equation so you can get this right and help patients. All right. 60-year-old unhealthy male, chronically with sleep apnea, COPD, poorly responsive, and stops breathing after getting sedation for an outpatient procedure. Okay. pH 7.25. What do y'all think? High, low, or normal? It's low. Bicarbonate 34 when normal's 24. So that's high. PCO2 80. Ugh. Remember, a normal PCO2 is 40, so that's high too. All right, so pH is low, bicarb's high, PCO2 high. Which one at least matches the best for the primary disorder? Well, at least I could say, with a low pH and a high CO2, there's at least a respiratory acidosis happening, right? He's retaining too much CO2. That's happening, okay? Now, let's do the math. Remember, we have the table for acute respiratory acidosis. We would say the expected bicarbonate change, the expected bicarb would be, it should go up by 1 for every increase in the PCO2 by 10. All right, so let's do something here. So the PCO2 is 80, normal's 40, it went up by 40. Okay, so if this was all acute, respiratory acidosis, I'd expect the bicarb to go up by 4, right? It's 1 for every 10. PCO2 went up by 40, I expect the bicarb to go by 4. I don't know, so if the normal bicarbonate's like 24 plus 4 is like 28, his bicarbonate's like way higher than that. So why is that? Okay. All right, so we have to think a little bit deeply. So the change in the bicarbonate, it actually went up by like 10. So he's 34 where normal's 24, and the change in PCO2 is 40. This could be explained that he actually has a chronic respiratory acidosis underlying all this, and now has an acute respiratory acidosis, okay? So chronically his PCO2 is high. And when he's been like that for weeks and weeks and months, which is common in someone with COPD, sleep apnea, okay? So chronic respiratory acidosis, his normal serum bicarbonate may be 30, maybe even higher than that, okay? His normal serum bicarbonate is always a little high. Oh, and then he stops breathing after moderate sedation. Now he has an acute respiratory acidosis on top of that. The PCO2 goes up even more and the pH drops, okay? So this could be explained by an acute respiratory acidosis on top of a chronic respiratory acidosis. So complicated stuff. So you can have more than one problem, and I want y'all to be able to figure this out. And that is it.